Hi there, thank you so much for watching. We're going to talk a little bit about BCR-ABL tyrosine kinase inhibitors and the development of the drug class designed to target chronic myelogenous leukemia. Chronic myelogenous leukemia is a genetic change in early myeloid cells. Myeloid cells are a young granulate cell found in the bone marrow, and they're primarily responsible for the production of red blood cells, platelets, and most types of white blood cells. In the case of CML, myeloid cells become unregulated and they proliferate rapidly. Granulocytes, a category of white blood cells, start to accumulate in the bone marrow and eventually spill over into the blood. Additionally, CML is categorized as a clonal bone marrow stem cell disorder. CML is a relatively common disease. It represents about 15% of all leukemia cases. In the United States, there's a projected 8,500 new cases in 2018. It's about a 1.4 to 1 ratio between men to women, so that breakdown is about 5,000 cases in men and 3,500 in women. On an international level, there's a projected 100,000 new cases in 2018, although as you get to the third world, the data is less reliable. The overall survival rate after 5 years for those who begin treatment is about 65%. For those who are able to catch CML in the chronic stage, the survival rate is over 80%, and with some of the new medications, actually over 90%. Like most types of chronic leukemia, the median age of diagnosis is later in life. For CML specifically, it's 65 years old. And the primary risk factor that increases the incidence is exposure to ionizing radiation. For those that survived the Hiroshima nuclear bombings, the incidence increased by a factor of 50. So there's a pretty strong correlation there. Up until about the 1950s, there was no clear link between genetic abnormalities and cancer, but that became an area of significant interest. Two scientists in Philadelphia started working and eventually found a link between about 95% of chronic myelogenous leukemia cases and a chromosomal abnormality on the 9th and 22nd chromosomes. In this case, they found that part of the 22nd chromosome would break off and bind to part of the 9th chromosome, creating this fusion gene called the BCR-ABL. It's a tyrosine kinase, and what's particularly important is that it's always active and requires no activation via cellular messenger. This fusion gene activates the proliferation of proteins that control cell cycle, and it results in expedited cell division. In addition to the proliferation of granulocyte cells, BCR-ABL also inhibits DNA repair, and so the cells are more susceptible to genetic abnormalities moving forward. In this graphic, you can see pretty clearly what happens with the Philadelphia chromosome. Part of the 9th chromosome, the ABL portion, breaks off and binds to part of the 22nd chromosome, the BCR portion, and it results in a fusion gene, which is abnormal and is found in about 95% of CML cases. So since the BCR-ABL fusion gene is primarily responsible for chronic myeloid leukemia, it was the target of most therapy developments. This fusion gene is only present in unhealthy cells, and so this allowed for scientists to focus on finding something that would have strong selectivity and inhibition for the BCR-ABL protein. And if they were able to do this, there would be no effect on healthy cells, and it would only affect the cancerous cells. So with that, scientists decided to try to pursue something that could effectively bind to the BCR-ABL cells and inhibit all of their cancerous activity, with the ultimate goal of leading to apoptosis in those cells. Eventually, through a series of tests, they found a drug called imatinib. Imatinib also inhibits other types of cancers, but it's most notable for its treatment of the chronic myeloid leukemia. So imatinib binds to the BCR-ABL kinase domain, and what it does is it prevents the transfer of a phosphate group and the subsequent activation of a phosphorylated protein. This then inhibits the activity and does not allow for rapid proliferation of the granulocytes, and eventually it ends up killing the cells. As you will see, BCR-ABL activity is incredibly important, and imatinib has proven to be a very successful drug in the treatment of chronic myeloid leukemia.
In the early 1990s, Dr. Brian Drucker teamed up with scientists at Novartis to work on finding a small molecule to inhibit the tyrosine kinase activity of BCR-ABL, as previously described. After conducting a high-throughput screening, they discovered the compound 2-phenylamminopyrimidine in 1992. This compound exhibited unusually high selectivity, something the scientists were unable to explain at the time because very little was known about the target, BCR-ABL. Essentially, Novartis found a needle in a field of haystacks, and as a result, was able to create the first-in-class drug for these tyrosine kinase inhibitors.
Moving on into the lead optimization phase of the drug discovery process, the drug was optimized by first beginning with point A on the structure shown, in which the compound had low potency and poor specificity, and so what they did to try to improve the activity was add a 3' pyridyl group at the 3' position of the pyrimidine as shown on the structure. Moving on, they then go to structure B, which is where they added a benzamide group to the phenyl ring to improve activity against the tyrosine kinase specifically. As they continued on with the lead optimization phase, they still weren't satisfied with where the drug was and how it was performing, so that is when they decided to add a methyl substituent in the ortho position to the pyrimidal amino group, which reduces activity against PKC. And the key observation from the analysis of the structure was that substitutions at this 6' position led to the loss of this PKC inhibition. However, the introduction of what's known as the flag methyl group retained or enhanced the activity against the tyrosine kinases, which ultimately led to potent inhibition. And finally, to end the lead optimization of this lead, they added an N-methylpiperazine ring at structure D, which increased the water solubility and oral bioavailability, since before then the series of compounds had poor bioavailability and solubility. The attachment of this highly polar side chain markedly improved both of these aspects of the newfound drug. And as such, this newfound compound had the highest selectivity for growth inhibition of BCR-ABL expressing cells and came to be known as imatinib. Moving into the structure-activity relationship of imatinib, since the crystallographic studies have revealed that imatinib binds to the kinase domain of ABL only when the domain adopts the inactive or closed conformation. This is where the glycine-rich P-binding phosphate loop folds over the ATP binding site, and the activation loop adopts a conformation in which it occludes the substrate binding site and disrupts the ATP phosphate binding site to block the catalytic activity of the enzyme. The shifting of the aspartic phenylalanine glycine triad at the N-terminal of the activation loop results in the exposure of the binding pocket, which can be utilized by these inhibitors. Since imatinib binds via 6 hydrogen bond interactions, at the time of this discovery, in the absence of structural information, there was no clear explanation for why it was so selective until they were able to understand the binding to this inactive unphosphorylated conformation of the kinase. This blocks signal transduction, ultimately resulting in inhibition of proliferation and loss of viability. And moving on into the figure 2 X-ray structures shown on the slide, the conformation of the ABL kinase domain is in blue, in complex with imatinib, which is in orange, the activation loop, which is the magenta, and its closed conformation, which allows for the binding. The ATP binding loop, which is in yellow, folds down over the inhibitor, producing this induced fit. Defining that the imatinib binds an inactive conformation of ABL explains the selectivity of imatinib for ABL over closely related kinases, and shows how imatinib acts as a competitive inhibitor for this ATP binding domain.
Moving into the ADME properties, we first start with absorption for imatinib. As such, imatinib has an approximate 98% IV absorption, so there is no intestinal or hepatic first pass effects observed. As for the oral bioavailability, this is approximately 97%, with maximum plasma levels reached after 2 to 4 hours. Moving into the distribution, approximately 95% of imatinib is bound to the plasma proteins, predominantly albumin and alpha-1 acid glycoprotein. For metabolism, imatinib is biotransformed to the N-demethylated piperazine derivative as shown on the slide by cytochrome CP3A4. Imatinib is excreted via the feces and as a smaller concentration in the bile and urine, mostly as metabolites. Some interesting toxicity information is that the most frequently observed adverse events are edemas, nausea, cramps, vomiting, or muscular pain.
The pharmacokinetics for imatinib are reported here in the study conducted by French researchers. For patients with CML, in terms of dose dependency, with the 600 milligram dose, all of the maximum concentration peaks, or Cmax, were on average 6.8 milligrams per liter, while the 400 milligram doses were on average only 2 milligrams per liter. These Cmax values indicate that a lower dose would be more effective since it keeps the Cmax lower. After determining the correct amount for dosage of imatinib, the researchers also determined the optimal type of dosage, one single capsule or multiple capsules administered throughout the day. The mean Cmax for 4 by 100 milligram capsules was 1.7 milligrams per liter after ingestion. Thus, by breaking the 400 milligram capsule into 4 smaller 100 milligram pills, the concentration peaks are basically unchanged, indicating the best dosage for imatinib is a single 400 milligram capsule. The area under curve represents the total drug exposure over time, which is abbreviated as AUC. The AUC calculated over 24 hours were 24.8 milligrams per liter times hour on day 1 and 40.1 at steady state in patients receiving a daily dose of 400 milligrams. This shows that the amount of imatinib administered is directly correlated to the serum concentration. Overall, the kinetics of imatinib in patients with CML receiving a daily dose of 400 milligrams are characterized at steady state by a Cmax around 2 mg per liter, a terminal half-life of 15 hours to 19 hours, which is very good for this drug, and a total body clearance of around 200 milliliters per minute. Finally, the IC50 value, which indicates potency for BCR-ABL, is 0.25 micromolar, which is extremely high for a drug, as it should be in the 1 to 10 nanomolar range. Thus, this indicates that there is room for improvement with second-generation drugs to increase the potency. To recap, imatinib has excellent pharmacokinetics despite its unusually high IC50 values. This may be in part due to its following all of Lipinski's rules. The molecular weight is 493.62, which is under 500. The log P, which is a measure of lipophilicity, is 3.89 as predicted by mole inspiration, and that's under 5. The number of hydrogen bond donors is 2, also under 5, and the number of hydrogen bond acceptors is 7, which is under 10. So all of these follow Lipinski's rules for drugs. Although imatinib is highly effective in chronic phase CML, patients who have progressed to the advanced phase of the disease frequently fail to respond to imatinib or develop resistance to therapy in relapse. One way to measure efficacy of the drug is by testing a patient's bone marrow for complete cytogenetic response, which occurs when no cells with the Philadelphia chromosome can be found in the bone marrow. Nearly 20% of patients who take the drug do not have complete cytogenetic response, and others may have intolerable side effects or drug resistance over time. Loss of response and transformation to advanced disease occur mainly in the first 3 years of imatinib therapy, and the rate of overall survival is poor in these patients. Considerable progress has recently been made in understanding the structural biology of ABL, and the molecular basis for resistance, facilitating the discovery and development of second-generation drugs designed to combat mutant forms of BCR-ABL. By knowing more about the structure of the target, more potent forms of second-generation drugs can be formed. Examples of the types of resistance are BCR-ABL duplication and mutation, P-loop mutations, and T315I mutations. Mutations that alter the imatinib binding site without affecting the ATP binding site or the active site of the kinase are very effective at inducing drug resistance. The gatekeeper in the ABL kinase is a small threonine 315, that is not an effective stabilizer in the structure. However, mutation in this residue is the most common mechanism implicated in secondary drug resistance. Usually, the threonine is substituted by isoleucine or methionine and prevents imatinib from entering the ATP binding domain. Here are 4 different second-generation BCR-ABL TKI drugs that have proven to be effective against mutant types: nilotinib, ponatinib, bosutinib, and dasatinib. As stated previously, the complete eradication of CML in patients receiving imatinib was limited by the emergence of resistance, mostly due to mutations in the ABL kinase domain and to a lesser extent by molecular residual disease after treatment. The second-generation BCR-ABL TKIs, nilotinib, also known as Tasigna, and dasatinib, also known as Sprycel, showed significant activity in clinical trials in patients intolerant or resistant to imatinib therapy, except in those patients with the T315I BCR-ABL mutation. These 4 drugs are active against most mutants, with the exception of this mutation, the T315I. Current research is going into how to inhibit this, and with this mutation being inhibited, the success of the BCR-ABL TKIs will improve drastically. One advantage of these potent ABL inhibitors over imatinib may be that the IC50 and IC90 values for inhibition of kinase activity and cellular proliferation of BCR-ABL transformed cells are lowered by 1 to 2 orders of magnitude. Thus, more complete inhibition of BCR-ABL tyrosine phosphorylation should be achievable in patients. Nilotinib, one of the structures shown on the previous slide, is the second-generation oral TKI. It was designed based on the crystal structure of imatinib to be highly active against a wide range of imatinib-resistant BCR-ABL mutants and is approved for the treatment of newly diagnosed imatinib-resistant or intolerant CML. Nilotinib was designed to maintain binding to the inactive conformation of the ABL kinase domain while incorporating alternative binding groups to the N-methylpiperazine and preserving an amide pharmacophore to retain H-bond interactions with the glutamine and asparagine. Substitution of the N-methylpiperazine moiety present in imatinib by a phenyl group bearing trifluoromethyl and imidazole substituents in the nilotinib structure greatly contributes to the potency of nilotinib by reducing the requirement for hydrogen bonding. With nilotinib, there are only 4 hydrogen bond interactions compared with the 6 hydrogen bonds for imatinib. In addition, among patients with imatinib-resistant CML, nilotinib has not been associated with the toxic effects commonly seen with imatinib treatment, such as fluid retention, edema, and weight gain. According to one study, at 12 months, rates of major molecular response, which is the primary endpoint, were significantly higher in patients receiving 300 milligrams of nilotinib or 400 milligrams of nilotinib twice daily than in those receiving imatinib. This indicates that nilotinib is much more effective, and indeed, nilotinib is reported as 10 to 30% more effective and potent in treating CML patients.
As you can see on the next graph, we go into some sales data for imatinib. And so at its introduction, the price was an unprecedented $26,000 per year. And as you can see by the graph, this price slowly started increasing each year. And a generic version did hit the market in 2016, as imatinib was averaging over $120,000 per year at this point. And so within last year's fiscal year, imatinib turned a $1.9 billion profit. Although this may seem quite large, this was a 43% decrease, making this the 3rd highest grossing drug. As a result, Novartis developed nilotinib, which was just discussed, and this drug generated 1.84 billion in profit in 2017, suggesting that these second generation drugs could be catching up to imatinib in popularity as well as in effectiveness.
Another interesting fact about Gleevec is the legal case between Novartis and India. In 1998, Novartis filed for a patent for Gleevec in India. They were granted exclusive market rights in 2003, but at this point there were already generics being sold at roughly 5 to 10% of the cost. In 2005, the patent was rejected as a result of the new amendment to the Indian patent law, which stated that drugs had to differ significantly in properties with regard to efficacy in order to warrant a patent. This was a landmark case globally and is still discussed frequently when regarding the balance between monopoly and public good. Thank you so much for watching.